we, as you can tell, we're very dear friends, and we built, bless you, we knew each other because he was my boss in ICU at Baptist Medical Center Beaches. So he was like, you know, my boss. We worked, I don't know, 3 to 11 probably. And,
Yeah.
So I knew him like that. He was my boss, and he and some of the other male nurses there that were on, was a Rainbow Warrior, were always trying to get me to go on there because they knew I didn't play and they just wanted to all shoot me up. And I'm like, I'm not doing it. Thank goodness I never did. So we became friends then, and then we had this discussion about anesthesia school, and I had applied the year before, and I was on the wait list, and wasn't quite ready, but I thought I'll just apply, put on the wait list, and he applied. We ended up getting in at the same time, becoming friends through that. And you know what that means when you have, you've all got each other, but then you'll have 1 or 2 people that have got your back. And he's one of those guys. No matter what, if I call him in the middle of the night, hey, I'm in jail downtown Jacksonville, or I'd be probably somewhere more excited if I were in jail. Probably like that. I wasn't going to talk about that. But he would cover me, and he would take care of me. He wouldn't even ask questions. He wouldn't judge me. He would just be there. And that's the kind of friendships that you will build while you're here. You need each other, as he said, to get through this together. And he has chosen to volunteer to give back by coming here and doing a lecture, and you'll get a chance to work with them in the OR when you go to UF Health. The good news about Larry is he's a great anesthesia provider. I would have him take care of myself or the people I love any day of the week. The tough news when you're an SRNA working with Larry is you will find that he's very particular about how he likes to do things. And you may have already heard of his great reputation from those of you that, those students that are ahead of you, your mentors. He does what he does because he wants to take good care of patients. So every time you work with someone, when you work with me, when you work with him, when you work with any CRNA, they're going to have their way of doing things. You learn their way when you're with them, and I would take notes and then share it with your peers because they're going to work with them the next day. What matters to them? And share that information with your peers. Because we all approach this when we take care of patients as wanting to take good care of them. And it's not that Larry's way is better or worse than mine. I'm going to say that out loud. It's just that we may approach things differently. And it's okay. But from your point of view, it might be frustrating because you're going to work with different people different days. So take the best from each person. And when you work with certain people, know what they like. The first day, they'll let you know. And then the next time you work with them, if you're not doing the things that you discussed the next time, you might expect a little bit of disappointment from them because they said, like, this is the last time we worked together, this is what I said was important, and now you're not doing it, and you're like, oh, forgot. So write that stuff down, share with your friends. That'll help you get through clinical. It'll be a little easier for you. But so Larry has been, we were peers. We worked at St. Vincent's together for a while. And then he took a position at UF Health, and he's been there for how long now? For a while. 5 years. Are you kidding me? Because you were with us, what, a year probably, maybe about a year. We were thinking, isn't that cool? We got a job together. And then he's like, he got a bigger carrot at a bigger place, so he's doing all those big kinds of cases, as opposed to my world. So today he's going to share with you some information related to fluid, blood, electrolytes. Are you still involved with doing traumas quite a bit, or occasionally, or?
Yesterday.
Okay, good. So if you have questions related to that, because he's going to give you some basics, but then depending on the kind of case you do, some of this information changes. Depending on with an adult or a child, some of this information changes. And when you learn more about the technology, I think Dr. Pavlotti has gone over maybe FlowTrack and Vigileo, some with you. Did you do that? Okay, he will. And that's a whole other way to look at fluid management. So you'll be learning that too as you go along. But I give you Larry, I leave you in good hands. I'm just going to be sitting up here paying attention. And if you have questions, he's a great resource for you. And then you will recognize him when you see him in the clinical setting. And you go, oh, I know this guy. He came into the lecture for us. So that should help you feel more comfortable when you go there.
Thank you.
Thanks for being here.
Yeah, my pleasure. Morning. Any burning questions about students before this? Like something you're serious or something like that's usually the initial reaction is like, oh my God. Like I've been a nurse for X amount of years, and I thought I knew how to take care of patients, and I thought I was doing the right thing, and then you come to school and you do this. we show you stuff in the OR, and your initial reaction is, oh my God, how come I haven't told somebody? Because you have this limited amount of knowledge, but you are basically relying on people with more knowledge to tell you what to do when you have a question. Well, you're all smart. You all probably know what to do, but you're always relying on that order from somebody else. Write it in the chart. Now I can do what I knew I should have been doing in the first place. So it's scary because eventually you're going to be making the transition from order takers to starting to delegate responsibility to making your own quick decisions in the OR, because I see my patients starting to do this. And staying ahead of the game and planning your head and like rehearsing things that haven't even happened to you yet, so that when you finally do see that, you're like, I know what to do. And that's eventually what it's going to come down to. So good luck. There are people that will be mentoring you throughout the process that are tough. I will say this up front, we are not here to be your best friend. We are here to teach you how to save people's lives. And do an anesthetic like you would want your family member to be taken care of. So always kind of keep that in the back of your mind, that these are people and they have children and they're somebody's son or daughter, and the way that you take care of them, the way that you instill confidence in them, your own confidence to them, that, you know, I'm here to keep you safe, I'm here to keep you comfortable, I'm going to be the person watching over you, and you're going to be, hopefully, waking up at the end, and you're going to be good. You're not going to be waking up in pain. You're going to be waking up comfortable and happy, and maybe going home, or maybe being admitted back up to the unit, or maybe going back to a room on a floor. So, for my own history, I was an ICU nurse for over 10 years. So my critical thinking skills were, I would say, good. Some of you may not have been in the ICU for that long yet, and now you're jumping from that really fast-paced environment into another environment that's even more fast-paced. So bring your clinical skills with you. Talk to your patients. Don't be afraid to talk to your patients. They want to talk. They want to tell you what's going on. And that's how you glean a lot of information about what was my mechanism of injury, what happened, when did I get admitted, do they have a knowledge of what's going to be done for them in the OR, or do they not have a clue? And you're one of their best resources for information. Sometimes the surgeons explain what they're going to do, and sometimes you always explain to them, here's how we're going to do your anesthesia. Have you had anesthesia before? How did you wake up? Did you feel sick to your stomach? Were you uncomfortable? Did you have a sore throat? All these things, and that's going to kind of help guide your practice into what can I maybe do a little bit differently that didn't work so good this time, so maybe I want to do it a little bit different next time. And now my patients are waking up the way I wanted to. All important stuff. So let's see. So that's my lecture. This is kind of some of the stuff that I was just talking about. So interview your patient. Sometimes they are good historians, and sometimes they don't remember what happened. I don't know what kind of medication I'm taking, but I take something for blood pressure, and I take something for my cholesterol. So you're all used to kind of like looking through a patient's chart, finding lab work, finding out their past medical history, what surgeries they've had. This is all important stuff. Are they stable, not stable? Have they been NPO since like before midnight the night before? Did they have a sip of water this morning to take their morning meds before they came in? What did you have to drink? What did you have for breakfast? We cancel cases all the time because patients are like, well, they never told me that when I went to PAT, or they never told me don't take this, or we want you to take that. Like, we always want people to take their blood pressure medicine. We always want people to take thyroid medicine, because thyroid is really important first thing in the morning. That's when those levels are lowest. So those are the kind of things that you should get a really good, quick assessment of your patient, their status, are they tachycardic, are they hypovolemic, and I mean, all these things. Are their lab work really out of whack? And they need some potassium, or we need to replace some calcium, all those kind of things. And are they compensating? So young people tend to compensate really well. Elderly people, not so well. How's their skin turgor? Or do they look like they're dry? Because a lot of times we get people and they just look dry. Their eyes are sunken. Their skin turgor is poor. You can put your hands on your patients. Don't be afraid. Like when you introduce yourself, hey, my name's so-and-so. I'm a student nurse anesthetist. I'm one of the people who's going to be helping take care of you. And when you shake their hand, are they strong? Are they cold? Are they clammy? All kinds of things you can tell just from touching somebody. I was a paramedic for 5 years, so I was used to doing that stuff as well. Kind of know about the procedure that they're undergoing. Are they coming in for an X-line, where they're going to have a wide open belly and there's lots of insensible water loss? Or are they having a hand procedure where they're fixing a trigger finger? So there's a huge range of kind of cases you'll be involved in. So you've got to figure out how long is the case going to be? Are they going to have a lot of insensible loss or just minor insensible loss? Do you think that they're going to need blood? They're coming to you with the hemoglobin. Nowadays it's a lot different. Before we would send people to the OR and we transfuse them the day before. Now the general trend of thinking is we're not going to give anybody any blood. We'll just give them crystalloid. And as long as they seem to be compensating, then they come to you with a hemoglobin of 7, which I don't like. I'm like, why didn't they get transfused the night before? Why are you sending the patient with a hemoglobin of 7? Sometimes you don't have choice. Sometimes it's trauma. They're actually bleeding out in front of you. So is that the person that you want to have blood available for, waiting in the room? Do you want to hang blood on somebody in pre-op holding to like get them going? Because you know that they're going to be losing more. And you don't want to already know you're starting at a deficit and now you're going to end up being way more behind. It's always, always better to be ahead of the game. If you're going to start an epidural on somebody and you're doing a lumbar epidural and you know once you start injecting meds, they're going to start slowly becoming a little more hypotensive. So you want to give that person some fluid ahead of time and maybe prevent that hypotension from occurring. These are like most of our cases. They kind of run between an hour, hour and a half, 2 hours. Sometimes they go 3, sometimes they go 5, sometimes they go 16. And you're not the only person who's going to be in the case. So kind of think about stuff like that. This is something I say a lot. Worst favors to prepare. If you have this little voice in the back of your head that's saying, maybe I need a glide scope. Maybe I want a CMAC. Maybe I want fiber optic. Maybe I want to have a couple other adjunctive airway devices in the room. Like we have LMAs in every room, we have endotracheal tubes in every room, we have oral airways in every room, nasal trumpets. So if you notice things are happening and your inductions aren't going the way you want, and it's taking a little bit longer to intubate somebody, maybe you need a rescue airway. As long as you know you can ventilate somebody, you have all the time in the world. All the time in the world. I don't care if you want to give more drug, get somebody more comfortable, you want to mask them a little bit longer, always pre-oxygenate your patients, because the longer things take, some people compensate well, and some people want to just crash and burn you. So if you do an induction and you can't ventilate somebody, there's no reason in the world why you need to be pushing neuromuscular blocking drugs. Because if you can't ventilate them, and now you relax them, if you can't move air, and they can't move air, You can always give something, and if it's going badly, let them wake up. Change your plan and approach it differently in a minute or two. But as long as you can let somebody wake up and they can breathe on their own, you're okay. So all the kind of things you need to think about. There were times we were going to be putting in double lumen tubes to isolate one lung for another. And we always use fiber optic to check double lumen tubes. So once the tube is in, and once you know you can ventilate, we put a fiber optic scope down one side of the double lumen tube, so when it comes out, you can actually look at the cup. And our tubes are usually all left-sided tubes. So when you put them in, we want to steer towards the left main bonus. So, but we want to see the cuff on that side, that when it's inflated, it's isolating the left lung. Because we normally ventilate, you can ventilate to both sides, but then when you want to take one side down, we need to know that you can isolate a lung. And doing that is by putting that cup up in the left main stem. So you want to have fiber optic. All the kind of things you want to think about. There's a saying up there, don't let the case manage you, you manage the case. What I mean by that is, don't just sit and watch things and let things unfold in front of you to where now I'm having a problem and now I need to start treating something. If you know the surgeon's about to make a decision, which is very stimulating to an even unconscious person, maybe you want to give a little bit of fentanyl 30 seconds before that happens. So watch the cases, watch how the cases go. First, the surgeon's going to do this. Maybe they're going to localize. Maybe they're not going to localize. Then they're going to do this. So start to learn each case and like how the case progresses. So you have a better understanding in your head of what's coming next. What's coming next? Do I want to maybe increase my involvement in anesthetic agent before they make an incision, even if they're a little bit hypotensive? Because you know when this happens, their pressure's going to go up, their heart rate's going to go up. So in your mind, start to think about what can I do a little bit ahead of the game that's going to prevent my patient having these big hemodynamic swings, so that they don't get too tachycardic, so that you don't have to treat them with vasoactive drugs to get their blood pressure back down. You kind of treat them ahead of the game so that when stimulation happens, you don't have these big, profound swings. Yeah, remember that. Fortune does favor the prepared. So here's a nice, healthy, pink infant. Sometimes you'll see these people, but most times you won't. That's an unusual guy with me also. That's what you're going to see. This is the patient you're going to be taking care of. Do you smoke? Yeah. Yeah. How much do you smoke? 3 packs a day. How many years have you been smoking 3 packs a day? 40, 50. So right away in your mind, you know this guy's going to have respiratory issues. So try and get to know your patients. This guy may come to you already intubated in the ICU. So in this case, you know they're intubated. I'm not going to have to intubate them. That's my first priority when I get in the room. Put them on the ventilator so somebody can stop ambling. Put a little volatile agent on them. Depending on their blood pressure, maybe a lot of volatile agent or maybe just a whiff, just to kind of keep them sleeping. Traumas, we get all the time. I had a 20-year-old kid yesterday with a gunshot wound to the abdomen. Stable when he got there. But as the case progressed, he turned out that the bullet had transected multiple loops of bowel, liver lac, kidney injury. So young kids, they tend to compensate really well, right up until the point where they don't want to compensate anymore. And now you've got to fight on your hands. Now it's your job to give them fluid, give them blood, make sure your vent settings are correct. It's a lot to do. 2 main fluids that we use in the OR, primarily normal saline and LR. And I will tell you, in my facility, when patients come down from the ICU, they don't even have IV fluid hanging. I'm like, what is this? You're transporting a patient from the ICU in an elevator down to the OR, and what happens if they crash? You have no running line where you can push drugs, or so it's different today. It's different than when I went to school and when I was taking care of people in the ICU. And we'll see the same thing. Times change. IV fluid, we give it in the proper amounts, whether it's isotonic type fluid or hypertonic or hypotonic, will give you the different results that you desire. So pick the right fluid. I know you have the power fluid, so I'm going to spend more time just kind of talking to you because I know you all smell it. But if you have any questions, please just stop me. Stop me and ask. The thinking now is even changing where when I was in school, and when I was a nurse 100 years ago, you would never hang blood in anything but normal saline, right? If you're going to spike blood tubing, it's with binder tubing with normal saline. I see people now giving blood with LR. Times change, and studies change, and there's all kinds of new evidence that is coming out that teach you different things. So your losses are primarily due to water and electrolyte deficits, and usually replace them with isotonic fluids. We always call these fluids replacement type fluids. They're all referred to as crystalloids. Colloids are things like blood, albumin, fresh frozen plasma, FFP, all those kind of things. So generally the fluids that we use on the floor are hypotonic solutions. And they're primarily used to replace water, and we call them maintenance fluids. You've all seen a bag of normal saline, and those are the electrolytes that are in normal saline. Normal saline is isotonic, doesn't cause any shifting. That's a bag of LR, and those are all the constituents of LR. So this is the distribution of electrolytes in your body, intracellularly and extracellularly. So your sodium is your major extracellular anion or cation? Anion. And potassium is your major extracellular ion. That's your, when I think of ranges in people, like when I look at an ABG, I don't say to myself, well, the range of pH is 735 to 745. I just think 74. I just pick a number, a middle number. And is it close to that, or is it way outside of that? So your range of sodium normally is 135 to 145. If it's greater than 145, they're hypernatremic. If it's less than 135, they're hyponatremic. Pretty basic stuff. Here are all the causative agents of hyponatremia. And on this side over here, you can see what that will cause. So if people's sodium is way out of whack, they can have mental status changes. I'm sure you've seen that. Hopefully you've seen that already. Muscle cramping, weakness, lethargy, all those type of things. They can be agitated. Sometimes you'll have people with GCSs of 15, and other times you'll have GCSs, what's the lowest GCS you can have? 3. They don't open their eyes, they're nonverbal, they don't respond to even noxious stimulus. Some people are just like in a coma. They don't respond to anything. You ever go do a sternal rub on somebody trying to wake them up? And so people just lay there and kind of just laugh at you. A little disconcerting. Still more manifestations of these are hypernatremia, greater than 145. Potassium, keep in mind that ranges always vary. This is what we're normally taught. 3.5 to 5 is a normal K value. But in some hospitals, depending on how their machines are calibrated, and every hospital calibrates their machines differently. 5.5 can be the top of the normal range, and maybe the bottom of the normal range is 4. So keep in mind, there's always little bits of leeway. So don't always think that if somebody's outside the normal, what we call normal ranges, that's a bad thing. If they're compensating, if you don't see any outward signs of things like they can't maintain their hemodynamic status. Do you always see a peak T wave in somebody who has a K that's too high? No, not always. So keep in mind that you're basically assessing people on how they look right now. Their lab values may be off a little bit. Somebody's renal numbers may be off a little bit, but they're still okay. So use your own best judgment of what you've already learned so far. Things that can happen with elevated potassium and the signs and symptoms that you'll see with elevated potassium. Primarily, the defects that you're going to see in somebody is an EKG change. If somebody's potassium is really low or really high, that's the thing you look for, EKG changes. And your EKGs can change during the case as well. You may have somebody who's looking sinus rhythm for the first hour, and all of a sudden you glance up the monitor again, and you're like, what in the world? Like, now they're starting to throw PVCs. So you have to ask yourself, are they unifocal PVCs or are they multifocal PVCs? Are you all pretty good with EKG recognition and different rhythm strips and all that type of thing? Okay. It's a good thing to brush up on. Do you know the difference between Winky Bob versus second degree heart block?
Or junctional.
Yeah. What's the definition of junctional rhythm?
No P-wave induction.
Yeah, no P-wave, right? What's the definition of somebody who has a first degree AV block? All right, good, good.
I think Dr. Paparotti has been going over that with them.
Okay. You can have prolonged PR intervals in hyperkalemia. You can have peak T waves, but you don't always see that stuff. Sometimes in cases that are going to be going wrong, or somebody that you think may have cardiac issues, that's the kind of person that you want to start to think to yourself, well, I'm going to throw an A-line in this person before the beginning of the case. A-lines do a lot of great things for you. Not only do they give you blood pressures instantaneously, we don't have to wait for a cuff to cycle. And let me tell you this, you don't always have to wait for the blood pressure cuff to cycle. The lowest settings we have, I think, are every 1 minute, but usually we keep them at about 2.5 minute intervals. If they have an A-line, you can set your BP interval to every 30 minutes and make sure you're correlated. And you all probably know you can always make somebody's blood pressure whatever you want it to be if you have an A-line, because you just move the transducer, right? If I want the blood pressure to look a little bit lower, I just lower the transducer a little, or higher, I want to lower the transducer a little bit. That kind of stuff happens once in a while. Most times in the OR, it's good to have your transducer on the bed. So if you raise the bed or lower the bed, you always have to remember to like raise or lower it on a pole. But it's a great tool if I just got this feeling something's going wrong, or something's not quite right. So let me draw an ABG. I'll draw ABGs and going to run for you right then. So you can see if your electrolytes are going out of whack, or if I need to maybe replace something. Or maybe if I've been given LR the whole case and the guy's sodium comes back a little bit low, maybe I want to change to normal. All those kind of things to think about. Or hypokalemia stuff, I'll just read that. I don't want to take up too much of your time. I know it's early in the morning and 2 hours. How do you treat hyperkalemia? What's the thing you normally would treat hyperkalemia with? What causes potassium to shift back? What? Can you give calcium? Calcium will shift potassium, right? of things associated with a low K. Lots of people will come to you with NG tubes. They're going to have abdominal surgery or something. So they have an NG in, it's constantly suctioning. That can lower your potassium. Just like people that have diarrhea, their potassium is low. What about somebody who's going to GI to have a colonoscopy? What do they do to those people at night or the day before? Yeah, they haven't drank it. Okay, I drank it one time. I was having some weird abdominal pain. So it's basically salts that you're drinking, and it sucks all the potassium out of you, and then you have horrible diarrhea, and so those people need fluid, right? So when you see them in the GI lab, and they get an IV started, or you start their IV, do them a favor, give them a little bit of LR. Start tanking them back up. The more treatment of it, when I was in the ICU, how much potassium would you give and how quickly would you give it? We had a rule, I don't know if you guys know something. It's usually what, like 10 milliequivalents over an hour. So if you're going to give them 20 a K, that infusion would happen over 2 hours. Yeah, you're in the OR now. And when you hang antibiotics, you don't hang antibiotics that go in over 4 hours. You don't give blood. You don't give a unit of blood in 4 hours. So we use a lot of ANSEP. And things change over time, but now the amount of ANSEP we give is usually, everybody gets at least 2 grams. And we redose it every 3 hours in the operating room now. So how do we mix ANSEP? In a 10 cc syringe, we reconstitute 1 vial in 10 cc, shake it up, draw it back out in the syringe, and then you put all that fluid in your next vial. Shake it up. So what I do is, if I can get the ANSEP early, I reconstitute it, and I mix it, and I leave my needle sitting in the vial, and I put my vial on the anesthesia machine. So it's already reconstituting, so when I come in the room, now that's one less thing I have to do when I get in the room, is start reconstituting antibiotics, because you've got plenty of other stuff to do. Plenty of stuff to do after induction. So think about doing stuff in that way, like portion favors is prepared, always be like a little bit ahead of the game. It will serve you well, I promise you. More electrolyte stuff, magnesium. You have these slides, so I'm not going to take too much other time. Calcium's a good drug to know about and use in your water. What is calcium really good at doing for your heart? Yeah, better squeeze. So if you look at somebody's lab work and you know their calcium's a little bit low, and now you're doing induction and their blood pressure's sagging, you may want to give fluid at first. I'm kind of a minimalist, so I don't like just pressing people right off the bat. I kind of think to myself, what's causing them to be hypotensive? Well, one is we just did induction. We probably got some Versed. We probably got some fentanyl. Now we're going to give propofol. I have a different way of inducing people with propofol. I don't just say in my head, I know the dose of propofol, they weigh X amount of kilograms, here's how much I'm going to give, and I just do this. People don't compensate well when you do that. Do I use etomidate instead of propofol? Not anymore. I never do. I never do. But you're going to. And people are going to tell you, let's use etomidate instead of propofol because it won't drop their blood pressure like propofol will. Well, the way I use propofol, it's very slowly as I'm pushing. My stopcock is open to everything, so my IV fluid's running. I have lidocaine that's already been sitting in the line right before I start pushing my propofol. There's a way to turn your stopcock and make that happen. I'll teach you that. You work with me. And I slowly talk to my patient. Like, what a novel thing. Hey, Jane, I'm right here with you. I'm starting to give you some sleeping medicine right now. you're slowly going to start just drifting off to sleep, and I'm going to stay with you the whole time. I'm going to be in the room with you the whole time. Because you would be surprised at how many people you will meet that think, I'm just going to be alone. And there's nobody watching me. So I'm going to go off to sleep, and then they're going to leave me while somebody's operating on me. People really think that happens. So I tell them, I'm going to be with you the entire time. And I'm going to watch over you, and I'm going to make sure you do good. And I'll see you when you wake up. And I talk to them about stuff like that as I'm doing this with purpose, slowly. So my patients' blood pressures don't bottom out. They tend to compensate if you do things slowly over time rather than do huge bolus things over a short period of time. So, and it's very comforting for people to know that I'm here with you. And I'm going to be here with you. And I'll see you when you're waking up. So, calcium is not something that we give rapidly. We still have it in syringe, and we still push it, whether you draw it from a vial or whether you give it from a cartridge, that kind of thing. But go slow with your calcium if you have to do it. You don't want to hammer people with calcium too quickly. Signs and symptoms, muscle spasms is a really common thing. It's also really common with magnesium being low. It's really common with potassium being low. Some of the metabolic effects of fasting. First, your body wants to use up your stores of glucose. And then when your glucose is all used up, what does your body want to start doing and breaking down to provide energy? What do they want to break down after fat?
Muscle.
Muscle, right? Not a good thing. That's not a good thing. Ketosis, all that kind of stuff. So here's like healthy adults that are undergoing elective procedures. And remember, there's a difference between something that's emergent and something that's elective. If somebody's coming in and I don't like the way they look, and they're getting their finger fixed, but their electrolytes are out of whack, their blood pressure's way out of whack, their sodium or their glucose is over 300, and they're having this elective procedure, I will make a good argument to my attending, or whoever else I'm working with, or the surgeons sometimes, right off the bat. And I'll say, it's an elective procedure. I don't like the way they look. Here's what I don't like about them. Do we really need to do this today? Or can we admit them? Sometimes we'll do that too. You'll admit somebody, you'll put them on IV fluid, you'll get their glucose under control. If their electrolytes out of whack, we'll fix that. And let's bring them back in a day. Or let's bring them back in 2 days. If I don't like the way somebody's lungs sound, and it's an elective procedure, they may not come off the ventilator. They may be older. They may become vent dependent. Now I'm able to breathe. Now everything feels really good. And then you try and wean them off the vent, and they don't want to fly. You can't extubate. That happens too. So always be thinking of stuff like that. So the predicted daily maintenance requirements for average, normal, healthy adults is about 2.5 liters of fluid a day. And that includes 20 milliequivalents of sodium and about 15 to 20 milliequivalents of potassium. So insensible loss is loss that occurs through evaporation, through suctioning out stuff through an NG tube, through diarrhea, all those kind of things. And urinary losses to maintain your average renal function is about 1 liter a day. And GI loss is about 200 a day. Normal, like I said, 1 liter to 1.5 liters in urine. You sweat about 1/2 to 1 liter a day. And your GI system, about 100 to 200 mLs a day. So you can change this number. Like I said, a lot of the things we do are in ranges. So don't always take everything as this is how it has to be. Some people can take a little less fluid during the case. Some people really need a little more fluid during the case, depending on blood loss, their insensible loss. So it's really important not just to look at the monitors all the time, but peek over the drapes and look at the case. Is this person wide open? Do they have a little incision? Are they working through a small operative site? Do they have a bone sticking out of their lower leg or out of their arm? So always watch your case. It's really important. Kind of learn how the procedures go. So now they're going to make incision. Now they're going to go through fascia. Now they're going to go through muscle. Now we're in the abdominal cavity. Is it an open procedure or is it a laparoscopic procedure? So in laparoscopic procedures, there's not that much insensible loss, right? Because they're just making little small incisions and they're putting ports through them and all the instrumentation goes through the ports, whether they're doing it manually or whether it's a robotic procedure. Robotic procedures always take longer. Anything you can do laparoscopically, you can do robotically, which for us kind of stinks because I'm like, why don't you just go in there and do the abdomen? Why do you have to hook up the robot to do that? It's a 20-minute procedure. Maybe 20 minutes at your hospital, nothing at my hospital, give you a 4-hour procedure. And then eventually they decide, no, we can't do it like this, we're going to go open. You know, so anyway, keep all that stuff in mind. So for me, when I was learning, I always picked 70 kilograms when I was dealing with a man, and I usually use 65 per kilogram when I was dealing with a woman. So for a 70 kilogram man, it's about 2,500 cc's per day as fluid maintenance required. So here's how we figure out fluid replacement. You got to figure out in your head what's just my maintenance fluid that I need to give during the case. That's constantly running. And I'm going to tell you, they're not on pumps. Everything's just hanging with IV and an IV bag and tubing. So you have to be kind of good at adjusting your roller clamp up or down to give more or less fluid. So here's how we do it. Their NPO deficit. So as long as they've had nothing to eat or drink from the night before, if your first case starts at 7 in the morning and they've been NPO since midnight, because you'll be amazed at how many people say, well, I went ahead and I had a sandwich and something to drink at midnight. And I'm thinking, why were you up at midnight? Why weren't you sleeping? You wanted to wait till like the very last second to get something to eat because you thought 7 hours later you're going to be dead from dehydration and malnutrition. So I'm like, I don't understand, but people do that. So we like to have people NPO for at least 8 hours, right, before they go to surgery. So there's rules and numbers that we use to calculate how much do we need to replace. First off, besides the amount that they're normally going to be requiring throughout the course of the day. So we replace stuff half the deficit within the first hour of a case, and then the other half over the next 2 hours during the case. Are your cases going to last 3 hours? No. Lots of them don't. So everything I say, just kind of take the information, but adapt it to whatever specific case you're doing. So if the case is really going to be short, like maybe over an hour, maybe you want to just run some fluid in. And don't worry about getting half in the first hour, and then the other quarter and a quarter over the next 2 hours, each successive hour after that. So insensible losses are, we look at them as like evaporative losses. So if somebody has a really small incision, maybe they're not going to really lose that much moisture out of that incision during the procedure. So that's like minimal. Maybe you want to figure that at 4 cc's per kilogram per hour.
Or even, wouldn't you say probably 2 to 4? Like, I would probably make it a range 2 to 4. And then the next one would probably be 4 to 6, and the next one would probably be 6 to 8 kind of thing.
So like I said, nothing is that written in stone. And adapt your case. If you think somebody needs more fluid, go outside your calculations and give them more fluid. is their urine output poor? I mean, so over the course of time, I'm like seeing no urine, their blood pressure's low, they're still a little bit tachycardic, give more fluid. Eventually you'll make the decision whether to switch from crystalloid to colloid, but that usually takes a couple to 3 hours. And Dr. Harmon's right. So, I mean, everything there's give and take. Nothing is ever just one specific number. So, you know all about third spacing of fluid. Third spacing usually takes place over time. Usually it's because people don't have enough oncotic pressure. Protein's low, they're not holding subject vascularly, and it starts to want to weep out into the extra vascular space, interstitial space. So there's a rule we use, the 4-2-1 rule. So about 4 cc's per kilogram for the first 10 kilograms of body weight. And to that, you're going to add 2 cc's per kilogram for the next 10 kilograms of body weight. You know, people weigh 70 kilos, 80 kilos. We see people that are over 150 kilos, over 200 kilos. It's amazing the people that you're going to be introduced to. But their requirements are much greater than the average sized person like us. Some people are extremely cachectic, and other people are, now they're not only morbidly obese, now they are super morbidly obese. So you're gonna have people that are over 400 pounds, 450 pounds. So the rules still apply. And then it's another 1 cc a kilogram for the rest of their body weight in kilos. So the formula works for kids and adults. In an average adult that weighs over 30 kilos, there's a simple way to do it. Just add 40 to the number of kilograms. So if you have a person who weighs 80 kilos, just add 40. And what do you get? 32. And that's your replacement number per kilo. That's your maintenance rate. So here's an example. So you have a 25 kilogram child. So for the first 10 kilograms, you multiply by 4. That's 40. For the next 10 kilograms, you multiply by 2, you get 20. And for the remainder, which is 5, you multiply 1 by 5, you get 5. So here's your answer. Here's your maintenance IV fluid rate, 65. If they're an adult and they're heavier, just add 40. So you take the deficit, how long have they been NPO? I'm using my number of 70 for this man. And you're 70 kilograms, so what do you add? 40, and you get 110. So that's their maintenance IV fluid rate. If he's the surgery is scheduled at 8 o'clock in the morning, then you take that 110 and you multiply it by his deficit over 8 hours. So you take the 110 times 8, you get 880. That's the deficit you're trying to replace. That's how long he's been NPO. So you give the first part of that 880 in the first hour. Like I said, not written in stone, but so you would give 440 cc's of replacement for his deficit in the first half an hour. And then over the course of the next 2 hours, you give the other half. So a quarter of it the next hour, 220, a quarter of it the next hour, another 220. And then it's okay to give it faster if you want.
How does this compare to those ICU patients that have been NPO for days and they're on lipids or just fluid?
So you see your patients in the ICU, and what's the standard maintenance rate for on IV fluid? I always see 110. 110, 100, they're NPO, they're not drinking. Do you think that guy has a deficit? Oh, heck yeah. So use the same formula. Use the same formula. They're probably urinating more than are getting an IV fluid over the course of time, if their kidneys are dry. So are they dry, even though they've been getting maintenance IV fluid on the floor? Yeah, they're dry. Any questions on that? So here's how your cases are going to go. And I made this chart up with an 80-kilogram man who's been NPO for 8 hours, and he's having a hemicolectomy. So sometimes these procedures will be open, and now a lot of times you'll see them being done laparoscopically. If you can do stuff laparoscopically, minimally invasive, it's always better for the patient. They have less loss. Usually there's less bleeding. There's faster healing times because they're not going through musculature and lots of fascia and all that stuff, so they do better. But here's my example. So an 80-kilogram guy, so what do you add to 80 to get his maintenance? 40. So what do you get? 120. So 120 is his maintenance, and that maintenance stays standard throughout the entire case. To that you add other things, like what is his NPO volume I need to replace. So for the first hour, second hour, however long the case is going on, he's at 120. His deficit is what? So talk me through the process. He's how many kilograms? What do you add to that?
40.
And how long has he been NPO?
8 hours.
So what's your total deficit?
960.
What's his total deficit?
960.
It's 120 times
Times 8.
times 8. What do you get? Okay. So what's half of 960 for the first hour?
40.
So that's what you add there. That's how I got that. Y'all get that? Okay. And we replace the next half over the next, how many hours? In an ideal world where your surgeon's super slow and the case is going to go for 4 hours. And some do, because we're a teaching hospital where I work. So there's residents. And there's people learning how to do everything. Everything.
Raise your hand, okay.
So suturing an incision about this long for a resident can take an hour. And you're sitting there going, So sometimes, being who I am and how long I've been there and how people know me now, I'll be over the cave. I'll look over the drapes and I'll go, all right, I want 7.5s under, 8 overs, and I'm going to help. Okay, let me just help you close this incision. So, but that's how I got these numbers, okay? So your replacement, you don't really know what your replacement's going to be in the first hour because you don't really know what your insensible losses are going to be over the first hour. But over the next hour, you kind of figure out, yeah, I think I need to start giving some replacement as well. So 80 kilograms over 8 hours is how I got 460. So I added that in. Not starting initially, because what I'm saying is for this procedure, this hemicolectomy, and I'm making an example that it's an open procedure. So my deficit, I'm thinking 8 per kilo. So that's how I did that. 8 times 80 is 640. So that's my insensible loss. So that's my evaporative loss. So if your belly's open, it can be 8 to 10, 8 to 12. Is the person oozy? Are they weepy? And you'll see that too. So my replacement, I didn't want to give over the first half for insensible loss because really there isn't a whole lot of insensible loss in the first hour. It's after they make incision and after the case has been going on and the evaporation is taking place. So that's how I got the 640. So now you just come down your columns and you get a running total. So you'll add your maintenance, your deficit, and for your first hour, I should have given 600 cc's of fluid. Does that make sense? Okay. And for the second hour, you do your standard maintenance fluid, you add the other quarter of your deficit, 240, and now I have an hour's worth of insensible losses of evaporation from this big open incision that I said is 8, they'll evaporate 8 cc's, and I multiply it by the guy's kilogram body weight, I got 640, add them all together, and get 1,000. So for your second hour, you have to add what you gave your first hour, plus what you're giving your second hour, and that's why I got the total of 1,600. And likewise, throughout the entire rest of the case, you keep a running total. So if this case would have gone over 4 hours, I would have already made up my deficit in the first 3, so there is no more, right? But I'm going to give my other 640 for evaporative losses, but remember, they're going to be closing, so you're not going to have the evaporative losses anymore. So my running total for the 4th hour is only 760. So I added that to the 2,600, and that's why I got 3,360. Yeah.
To kind of piggyback off of
Finally.
to piggyback off of what Mandy asked, so if you have a patient that's coming from the ICU who's probably fluid down for days, do you go back to their I's and O's and like kind of account for those days of fluid? I mean, you
It's a
can't
good question.
replace all of that.
It's a good question. And you're right. They are going to be in a deficit. And always keep in mind too, that you don't want to just volume load somebody, like all of a sudden. What if your patient has CHF?
That's good.
And then you volume load them, and now what happens?
Well, one CHF.
Now they're in fulminant pulmonary edema, right? So you got
Right.
and their oxygen's dropping. Now what do you have to do? Give them a diuretic,
Yeah.
right?
And that's what I was thinking about. It seems to me like even 1,000 cc's in an hour for someone who's got a EF of 15% is a lot. But I don't know.
How do you alter the calculations for poor cardiac output?
This is pretty standard.
Okay.
This is the guideline you can follow. But remember, there's always, you have to use common sense. Unfortunately, common sense is something we can't teach you. You have it, you don't have it. You guys have it. So use your best judgment. So here's the things I start to look at. Is 1,000 cc's in an hour a lot? Not in the OR. Not in the OR. Is given 2 grams of ANSEF in 30 seconds too fast? Not in the OR. Do we give people blood on rapid infusers on a level 1?
Yeah.
In 30 seconds? Yeah. So your thinking is going to have to change a little bit.
Also, yeah, from the ICU mentality to the CRNA mentality, it's definitely going to change when you get in the OR. But this is a formula. We still teach the 4-2-1 rule as far as fluid management and replacement, but we also have flow track and Vigileo. So if you have someone come from ICU, they're going to be monitored up. And you're going to base a lot of your judgments on what they need based on what those monitors tell you. So you may not do the 4-2-1 write out the plan rule because you have other monitors that can tell you, do they need food, do they need inotropes, what do they need? So you're going to have, especially with the sick people coming from ICU, the questions you're asking are awesome, but you're probably going to have them on more advanced monitors than the 4-2-1 paper rule that we're teaching you. But you need to know this as well. And this would be our guideline, and this would be a starting point. But if you have monitors that are telling you different, that's what you go by. My answer to the question would be, I see how the patient's responding. If they're coming from ICU, I'm expecting them to be in deficit. But I'm going to see how they're hemodynamically responding before I decide what I'm going to do. And I'm going to have advanced monitors on Vigileo, FlowTrack, to help me make those decisions.
And it's a great point. And that's what I was going to tell you guys is, look at your patient, look at the monitors, and try to interpret the story that the monitors are telling you. Your patient can't. So is your patient hemodynamically stable or not stable? If you see big swings in blood pressure and heart rate, and you're given a little bit of fluid, to me, now, that's a sign of hypovolemia. When patients' blood pressures are labile, you gotta fill up the tank. So whatever that takes, if it takes using this guide and this is working, great. If you're using this guide and I still feel like my patient's behind the curve, look at your other signs and symptoms. Is my urine output okay? Is their blood pressure still labile? What do you think happens if you give somebody a vasoactive drug? Ephedrine and phenylephrine are two that we very commonly use. So, and there's choices why you use either, based on how big. So, if you want to peripherally squeeze somebody and use phenylephrine, you're probably going to get the desired effect. Is that desired effect going to last? Or do I give the drug and it works a little bit and now it's not working anymore? Or I give ephedrine because I want to get my heart rate up a little bit. And it's an indirect acting drug. I'm sure you know that already. But it works, but it doesn't hold. Why do you think it's not holding? There's no volume. So here's the analogy I use in the OR. You got a hose, your garden hose, right, from home. And it's only half full of water to here. And then you squeeze somebody, and you do this, right? What are you compressing first? Airspace, right? I mean, it doesn't happen. People don't have air in their veins like that. But it's the analogy I use. So liquids are not compressible, right? Gas is compressible. You have gas in cylinders, right, all the time. So if you go to squeeze the hose, and the hose is only half full, you're not going to generate any pressure. So what's your job first? Fill the tank. Fill the tank. Exactly. That's what we're supposed to do. So that's how this works. Here's other kinds of deficits. That obviously was from a trauma that we had. So what we do is we normally kind of like pile up bags on the floor. So at the end of the case, because do you have time to chart? Do you have time to like adjust everything all the time like this? No. Multiple hands on deck. You need as much help as you can. Somebody's hanging blood. Somebody is mixing drips. Somebody is charting. Probably the person charting is doing one of the most important jobs because that's not something you have the luxury of time in doing when that's going on. So, and you're going to see all that. So, abnormal fluid losses, hemorrhaging, sweating, diarrhea, vomiting, bowel obstructions, sepsis, all these things can cause people to vasodilate out. They can cause you to lose a lot of fluid. So you have to keep all this in the back of your mind. So the abnormal fluid losses are kind of difficult to calculate. And it may entail more than just water loss. So you have to be prepared to replace people with colloid as well as crystalloid. And I will say that you can continue to give crystalloid and start to like hemodilute people out, and then they're going to start third spacing on you. And it can actually happen during a case. What if you have a case where somebody is in steep Trendelenburg? That may help you with your pressure. But if you're giving that person a lot of volume at the same time, where's all that volume going to end up? In their face, right? So there's a general rule that gravity always wants to pull things down. Every time I jump out of the plane, I know I'm going to meet the ground. It's how I meet the ground that's important. They know I'm going to make it there. Well, when people are in steep T, fluids always want to flow to the lowest point. So that's a case where maybe you want to be a little bit more mindful of how much fluid you give. Maybe once they're back supine and they're flat, not in T-bird, then maybe that's the time to replace some more fluid. Maybe not while they're in T. So what about people that are prone? You're going to be doing a lot of prone cases too, right? For back surgeries. So your patient's prone and they're in a face pillow and you feel like you got to give a ton of fluid. What are lots of studies now showing about people's vision? When you give a lot of fluid and they're prone, or they're maybe in steep T, and you're really volume loading them, what can happen? Yeah, so you increase pressure, right? So lots of studies are showing now that patients can go blind. because you have pressure on your optic nerve, your blood flow's diminished. They can maybe wake up with blurry vision that comes back, or there have been studies done where people have actually lost their eyesight. So you really want to be mindful of something like that. So that's actually a guy's face. Pretty graphic. I mean, it's so swollen that there's no cheeks, there's really no discernible eye sockets or anything.
Is that an entrance or exit gunshot wound?
What do you think that is?
The entrance.
I don't, I mean, that's what it looks like to me, I don't know what it is.
It could be both,
I feel like the way the skin's falling,
right?
it looks like it.
It could be both. That's a bullet hole. Maybe on the other side, it's this big. Yeah, that's bad.
Would we call that a good picture of third spacing? Or a bad picture of third spacing?
Bad.
I
Bad.
mean, it depends on what your goal is.
And imagine what's going on the inside airway wise.
So that's another thing you always have to be mindful of. Do you think super morbidly obese people are super morbidly obese just out here? Or do you think they may have a lot of redundant stuff inside as well? Yeah. So how far can you open your mouth for me? Stick out your tongue for me. How far can you stick out your tongue? And you see nothing. Nothing. That's a case where maybe you want to have a wide scope in the room. You know? So when you see people like that, or patients, you may see patients that have very limited mouth openings because they've got a big abscess, or they've got a parotid gland that's like super swollen. So how far can you open your mouth to me? And they can't. Why? Because there's some edema, and because it's painful. Do you think you may be able to do a better job once you have a little bit of muscle relaxation on board? Yeah, now their mouth opening is really super big. So that may be a case where maybe I don't need black scope. But that's up to you to determine. And we kind of are looking at you guys to like make an assessment, make your best judgment, and have whatever ancillary equipment you think we may need in the room. You'll never be faulted for having too much crap in the room. Okay? So it's always better to have everything you may possibly need, and then it's at your disposal, rather than I should have had fiber optic in here. I should have had a glide scope in here. And now you've got to hold up the case, and you've got to call a tech or somebody to go get the piece of equipment you needed that you should have had in there. So those are the kind of things we want on your eval. Everybody doesn't always get these glowing, doesn't need any improvement evals, especially initially. Well, but keep in mind, we're here to teach you. And we know that you don't know everything yet. I don't know everything yet. I've been doing it for years. So you're going to get evals where you just look at them and you go, damn it, why wasn't that better? But just think about, we're assessing you to get you better. So if you never had to improve on anything, you're going to be doing this, right? So take it as a learning environment. And we're trying to help you, and we're trying to teach you. That's our job. And sometimes we may raise our voice. Sometimes we may get a little excited. But it's like, come on, come on, come on. You're seeing this, you know what to do. What do you want to do? What do you want to do? And you're like, well, I could get this, but maybe I, and all this time the clock's ticking. And your patient's doing this. It happens. So take it as a learning experience. So all these fluids that you're going to want to replace, it depends on the degree of surgical trauma. And like Dr. Harmon was saying, minimal can be 2 to 4, moderate can be 4 to 6, severe, meaning the opening or the incision, can be 6 to 8 to 10 to 12. There's blood loss involved with all that as well. You got to keep in mind too. So minimal, you want to initially start replacing with crystalloid. Now, if you know you've got somebody coming to the OR and they've got a hemoglobin of 6, and it's going to happen, what may be initially the thing you want to do, but in the back of your mind you're thinking, I want to get this going as fast as I possibly can. Start giving a crystalloid, but have blood coming, or have blood waiting in the room for you. So initially start giving them fluid, and then as soon as blood gets there, that's the more important thing, because that's gonna keep your oncotic pressure. That's what's gonna keep the boxcars full of oxygen, right? So they're gonna be ever oxygenated. That's a big whack. That's an open hemicolectomy. Valves exposed, fats exposed, vessels are exposed. That's a big blood loss. So for me, that's an 8, at least an 8. That is a 6. Looks gnarly, but I mean, the amount of surface area exposed, I mean, your abdomen has a lot of vasculature in it, right? Your aorta's in there, your inferior cava is in there, there's lots of blood flow. So you'll lose a lot more in sensible loss with a lot of vessels being exposed. Something like this, even though it looks pretty bad, probably not nearly as bad as an open zone. So I call that a 6, I call that a 4, I call that a 2, just for frame of reference. Osmotic activity of high molecular weight substances like colloids tend to want to pull things intravascularly. So I think of colloids as like a big gigantic planet. So if you have a big planet, it's got a lot of gravity, right? Gravitational pull in a large planet is much greater than gravitational pull on Mercury. So that's how I look at colloids. So if you think you're going to start running into a scenario where you're going to start third spacing, maybe crystalloid isn't the most important thing anymore. Maybe it's blood, PRBCs. Maybe it's hetastarch, which a lot of those kind of colloids you don't really see a whole lot of anymore. Albumin is a great choice. Several are generally available. They're mostly isotonic in these solutions. Blood-derived colloids are albumin. And I'm sure you've seen albumin on a unit, and it comes usually in 5%, which is what we get. But it also comes very concentrated in 25%. I have never given 25% albumin. Can you have reactions, blood reactions with albumin? Yeah. So one more thing to be kind of mindful of and be careful of. Just because it's albumin and it came in a bottle, and it still came from somebody, right? Hetastarch, you don't really see that much anymore. It was provided in a 6% solution. Do you still see it?
We rarely use it. The other one is there's hetastarch and Hespan both. We rarely use it. One's in LR, one's in normal saline, but we used to use it quite a bit. It's really gotten out of favor based on the evidence they found. It doesn't work as well as either blood or albumin or crystalloid, depending on what you need. So we used to use it, but I haven't used it in years.
Yeah. I just don't see it that much anymore.
No.
There was another one too called pentastarch.
Yeah.
And I don't see that one anymore either. There it is, pentastarch. It's a lower molecular weight starch solution, but it's much less likely to cause any kind of adverse reaction. And they were thinking that eventually that was going to replace hetastarch because it would actually cause intravascular pull like over 4 hours. So a long period of time, whereas other things don't really last that long. You all know about blood. It's probably the best thing you can give. In the military, I don't know if you've ever seen this. They could give whole blood, which is probably the best thing to give. Because when we give blood now, it's like for every unit of blood, attack cells, usually you want to give a unit of cryo or FFP and a unit of platelets. Because you don't get all that stuff. You don't get all of it in attack cells, but you do in whole blood. So plasma is the extracellular part. Platelets are your primary hemostatic agent. You all know they form plugs and fibrin and all that stuff. And leukocytes, your white blood cells, are primarily to fight infection. So that's what a bag of platelets looks like. 1 unit of platelets, it can increase your count by like 5 to 10,000. So what's a normal platelet value? Yeah, well, everybody said 150. 150,000. Usually we start giving platelets when the count gets below 50. Transmission of viral disease can happen, especially if you're using pooled donor platelets. So when you say like pooled, using the pooled platelets, that can come from as many as like 10 people. Something to keep in mind. That's what FFP looks like. A single unit of whole blood that's frozen within 6 hours is where you get it from. It contains all the coagulation factors. You use it to treat hemorrhage. It's really not needed unless your PT and or your PTT is greater than 1.5 times normal. So like, what's a normal INR value? 1. So for every degree above 1, it takes you to clot. That's how far off your INR is. So 1 is normal. If you have an INR of 2, you're going to clot twice as slowly. What it means. The urgent reversal of Coumadin, warfarin, is with FFP. How else can you reverse Coumadin? Vitamin K. So keep in mind that patients that eat a lot of dark green leafy vegetables, their numbers can be off a little bit. And they clot a little bit faster. The fraction of plasma, this is cryoprecipitate, is precipitated out when FFP is thawed. So it's useful in treating hemophilia A, has a high concentration of factor 8. What's factor 4? Just throwing that out there. The clotting cascade, what's factor 4? Sorry, I looked that up. It contains more fibrinogen than FFP does. So RBCs provide about 70% of the body's acid-base balancing capacity. RBC membrane has specific proteins on it, and it's integral for your body's immune system. This is all why when patients are ABO type specific, we like to give exactly what they have, but sometimes you can give different things. Like, what's the universal donor? What is it?
It shouldn't have an RH surface to it.
Okay. What's the universal recipient? What? Right. You gotta know this stuff, right? Somebody gives you a bag of blood, and you're reading off. It always takes 2 people to check blood, right?
Yeah.
So you're reading off the bag, and you're like, here's a patient's name, here's their MR number, and when you have a blood band, and they put a little sticker on the blood band, and they send that off also, you have to check that the stickers match. So when you get blood back, you're not only checking for that, because sometimes you'll read the units APOS, the patient's EPOS. It happens. Your responsibility. So what happens if you give a patient that's BPOS, APOS blood? Yes, and they can be bad. They can be really bad. Do transfusion reactions always occur right now? It can happen how much later? Days. You can have a transfusion reaction days later. So just keep all this stuff in mind. So here's my little chart about blood groupings. The recipients, the donors, who can get what, and I'll leave this up to you to put to memory. More of the same stuff. You ever hear of Rogan? Have you ever seen it given? Do we still hear it? Yeah. So tell me about Rogan. What happens? You got a mom that's RH what? Negative. and you got a fetus that's Rh positive. So you give, or you have an order to give what? Okay, so what does RhoGAM do?
Makes it so the mother's immune system doesn't
What if,
attack the
I mean, the mom's one blood type, but the fetus has a different Rh negative factor. So what can happen?
But it's only in the second pregnancy.
Correct. Correct. So what can happen?
The mom will develop an immune system against.
Yes, exactly right. So it's just like any other kind of immune response or a response that one of you is exposed to. Let's say you tell somebody you have no known allergies. I've no drug allergies, right? So somebody has no allergies and somebody gives them something sulfur-based, okay? Do you necessarily see a reaction immediately? Yes, no, maybe. No, you may not. Because the first time your body's exposed to something, it becomes sensitized, right? So now your body starts producing antigens to that specific antibody. So the first time you receive something, you don't necessarily have a reaction. What happens the second time your body sees that? Really bad. Full-blown anaphylaxis maybe, right? Biomedical emergency. So same thing with blood typing with mom and infant. So that's why we use RhoGAM, because they're exposed to something the first time. The fetus is kind of a foreign body, right, to the mom. Pregnancies aren't always these happy, everything's perfect, deliver a normal baby scenarios. Bad things can happen. So that's why we give RhoGAM, because the mom's gotten sensitized. So the next time she sees that foreign substance again, she can go to full-blown anaphylaxis, or fetus can be aborted, right? So, and that's an IgG reaction, an IgG type reaction. So here's your blood considerations. Acute blood losses can range from 1,500 to 2 liters, or approximately 30% of your estimated blood volume. And that really exceeds the ability of crystalloids to compensate for. That's a case where now I need to really start replacing blood. So there's other formulas we use where we can calculate what's an okay amount of blood for somebody to lose during this procedure. Because blood loss is acceptable. How much is acceptable is another question. So we have formulas. You lose too much blood, you jeopardize your urgent carrying capacity and all your compensatory mechanisms, and then all of a sudden your hemodynamics get out of whack. So we like to think that we continuously monitor blood loss. So you peek over the drapes once in a while, you look in the suction canister, you look at gauze pads, you look at lap sponges, and in your head, you come up with an estimated blood loss. What do I think my patients lost at this point in time? So if it's a small amount of blood loss, you can kind of make up that deficit with crystalloid in a ratio of what? 3 to 1. So for every cc of blood you lose, you replace with 3 cc's of crystalloid. So if there's 20 cc's of blood loss, we need 60 cc's of crystalloid. If you're going to replace blood loss with colloid, with blood, packed cells, you replace 1 to 1. Yeah, I think they lost a liter of blood. And you may have to look in the canister and go, hey, my canister has 1,000 in it, but I don't think that's all blood. So you peek over the drapes and you say, how much irrigation have you used? Okay? This is all calculated stuff in your head. So there's 1,000 cc's in the canister. We lost, we've given 800 in irrigation. Okay, you lost 200. So now if you want to replace that with blood, 1 to 1 ratio. Intraoperative assessment is you visually just look, and it's an estimate. It's going to be spot on? No. That's why they say E, estimated blood loss. So sponges, labs, drapes, suction canisters, all those things, and you come up with a figure. Is my patient becoming more tachycardic now? Is my pressure starting to sag a little bit? So you measure all this stuff in the suction containers, you have to account for irrigation, sponges, laps, and so a 4x4 soak is about 10 cc's, and a lap pad soak is about 100 to 150. It's soaking wet. So you make calculations for all this, and there's multiple formulas that exist, so I'm going to teach you one. So your estimated blood volume, you can calculate. So it's a function of total body water composition, and it decreases with age. So preemies, it's about 100 to 120 cc's per kilo. In newborns, 80 to 90 per kilo. Infants, age between 3 and 12, 75 to 80. Adult males, I'm going to use my same numbers before, 70 per kilo for an adult man, 65 for a female. You can use 75 for a man, you can use 70 for a woman, doesn't matter, just as long as you have a basic ballpark estimate. So here's my adult guy, he weighs 80 kilos. You might see a guy like this, maybe, not in trauma centers. So I'm going to say that he has basically 70 per kilo. So do the math, you get 5,600. That's his estimated blood volume. In an adult female, I use 65. She weighs 65 kilos. Do the math, you get 42.25 mLs of blood. How much blood do you guys think is in a bag? Everybody says 350, right? Are some bags of blood bigger than other bags? Yeah. Is there a volume of blood on the bag, the packed cells? No.
Some yes, some no.
Sometimes.
Yeah.
I don't know if I've ever seen it. Maybe I'm not looking. Anyway, are there volumes on bags of like cryo?
Yes.
Yeah. So I don't know why they're not on everything, but anyway, you can account for that volume like when you give cryoprecipitate. But if you give a unit of blood, and everybody says 350, and I'm looking at a bag of blood, and I'm looking at a bag, a 500 cc bag of like normal, they look kind of the same to me. So it's just me, but I think more like 500 in a bag, not just 350. It just seems, what do you think?
I don't know. I wish we knew, because it would help us be more accurate. But everyone says 350.
Everybody says 350. So here's your formula. So if you know what your starting hematocrit is, and you can kind of calculate what is your allowable blood loss. You can say maximal or minimal, doesn't matter. Blood loss. And here's how you start the formula. You take your allowable blood loss, what you're looking for, and the way you find it is you start with your estimated blood volume. And that was where we took like the 80 kilogram guy times 70, and you got 5,600 cc's of circulating blood. That's kind of basically what they should have circulating. So you take that value, you multiply it by what's your starting hematocrit, and how low do you think your hematocrit can safely go to? So what's a good hematocrit for somebody to start at? Just ballpark number.
35.
Mid 30s? Okay. What do you think is acceptable for somebody's crit to drop to? 20?
Yeah, 21.
21?
That's low.
18? Maybe? We're saying no. Lots of exceptions in the OR. So the other things you're looking at, like Dr. Harmon said earlier, is hemodynamically, what does my patient look like? Are they starting to suffer, or are they still kind of maintaining? So maybe a little bit more blood loss is still okay.
And it also depends on what their starting crit is. If they're historically or chronically low, they may be able to tolerate better than someone that's not. So it just depends. A lot of times when I do this calculation in the OR, I say my target crit is 30. They could probably go lower, But I want to know that if the crit is 30, once I've done this calculation, that when I see X number of cc's in the canister, I'm like, okay, the crit's probably about 30. So now we're starting to look at, okay, maybe we're going to be getting in trouble where we might have to start replacing. That's how I do it. And to me, that's erring on the side of, the side of error.
Yeah, 30 is a big number.
I'm more conservative, and that's not what you're going to see probably at level 1 trauma centers.
Yeah.
But I'm dealing with people that are basically healthy that are coming in for
Right.
elective surgeries mostly.
I mean, how often do you see somebody with a crit of 45? I mean, that would be ideal, but you're not dealing in an ideal situation.
Right.
Most of these people are, unless they've been involved in some kind of trauma, and before this trauma, they were a healthy, young, non-smoking, don't do drugs. I've asked people the question. So besides the prescription meds you're taking, do anything else? Some people are really reluctant to answer. I'm like, look, I'm not the cops. I don't care what you do. It just helps me take care of you better. So I'll say, do you do anything? Do you smoke marijuana? Do cocaine, meth, heroin, whatever? And they're like, yeah. I'm like, which? You know, oh. Oh my God. So, anyway, you do the calculation. So you take your estimated blood volume based on the kilogram body weight, male or female, right? And you subtract what they start at with what you think is acceptable to go to. You do that subtraction, and then you divide it all by their starting crit again. And you get a number. And the number indicates how many cc's of blood do I think they can lose comfortably and still be okay. Some people that start with really high crits can lose over a liter or a liter and a half, and they're still going to be okay. I don't advocate smoking, but what's the trend that you'll see when people smoke corresponding to their hematocrits? They're higher, right? Why? Because your body is constantly ingesting carbon monoxide, carbon dioxide. These are all like non-O2 carrying gases, right? So the more your body's exposed to that, what does your body do? Your brain tells your kidney to secrete more erythropoietin, so your red blood cell in long bones gets increased. So their crits can be high.
Why do you choose to work with crit instead of HP? Just
Instead of
we
hemoglobin.
Blood loss
The
and
hemoglobin?
transfusion boundaries, we use hemoglobin instead of HP.
So I don't have a great answer for you because, I mean, if you look at hemoglobin and somebody comes in with a starting hemoglobin of 14, 15, 16, or whatever, which you don't see often, how do you figure out hematocrit? Your hematocrit is what times your hemoglobin? 3, right? So basically you have somebody come in with a hemoglobin of 9, you figure their crit's going to be, or not 3, it's going to be higher. What is the number you can take your hemoglobin and multiply it by? Is it?
I think it is.
3 for crit.
Yeah, because it'd be 20.
So, I mean, you can get a basic ballpark. So if somebody comes in with a hemoglobin of 9, figure their crit's about 26, roughly speaking. It's usually like a tiny bit lower, but I guess they think that hematocrit is a much more sensitive, accurate thing because the hematocrit is not always 3 times your hemoglobin. It can be lower, it can be higher. So they choose to use hematocrit.
If you guys, in Europe, do you typically do the hemoglobin? I mean, yeah, okay.
Yeah.
We use like the 4-5-6 rule, and if your patient is healthy and ACE1, you just start transfusing when they have the hemoglobin of 4. But when somebody
Of 4?
Yeah. But I think hemoglobin is a different measurement.
Yeah.
Maybe than here, because
Maybe it's different.
most of our patients are like come in with HB of 8, 9. That's normal.
What's the
Yeah.
an acronym you're using? H what?
For
B?
Yeah.
B Bravo?
Yeah.
Yeah. Maybe it's measured differently.
Yeah.
And again,
So,
that's what I was saying before. Like all the measuring equipment, whether it's from UK or here, or even amongst different hospitals here, they calibrate their own machines. And they come up with a range that's acceptable. If you're within this range, you're normal. If you fall below or above, it's abnormal. So maybe the calibration is just a little bit different. I don't know.
Yeah, maybe we have another.
And different units
Yeah.
that you measure with.
Yeah,
Yeah.
it could be.
What's
It could be.
normal?
So this is just a real quick example of an allowable blood loss or acceptable blood loss. If you have somebody who is a male who weighs 70 kilograms, and I figured him at 70, so you do the calculation, 70 times 70 is 4,900, and then you do your crit calculation, so he has a starting crit of 45, rarely, and you're going to say, like Dr. Harmon, he can drop to a crit of 30 safely, so you do that subtraction, you get 15, and you divide all that by the starting crit of 45, and that's the acceptable or allowable blood loss. 1,633 cc's. So over 1.5 liters of blood. What's the average blood loss in a C-section? Average.
Depends on the doctor.
Yeah, it does.
800.
We say a liter. A liter. Now, mom's blood volume is how many times normal? Twice, right? Twice more. So they can lose more. Okay. So some schools have thought proposed that you don't really have to transfuse unless their crit goes to 24. And that would correspond to hemoglobin of 8. We have people coming to the OR with hemoglobin of 8. We have people coming to the OR with hemoglobin of 6. So keep all that stuff in mind. And again, use your best judgment. You know 1 unit of packed cells is going to increase your hemoglobin by what, a gram per deciliter. A 10 ml per kilogram transfusion of packed cells is going to increase your hemoglobin by 3 grams per deciliter. And the hermetic grit by 10%. Adequate oxygen delivery and organ perfusion is by packed cells. Your normal electrolyte concentrations and your normal glucose concentrations all keep you hemodynamically stable. So this is a prepped out person. Your compensatory IV volume compensates for that anesthetic effect. So every time you induce somebody, every time you give them fentanyl, every time you give them Versed, every time you put them on volatile anesthetic agents, all the agents we use are vasodilators, right? So you intubate somebody, you get a tube in them, you flip them on the ventilator, turn on your agent, do your settings, how many times a minute do I want to breathe, how many cc's of volume do I want to give them, how fast do I want to put PEEP on them, or not PEEP? All those things kind of tend to contribute towards somebody becoming more hypotensive. So you have to maintain hemodynamic stability. You have to administer volume to expand your blood volume and your intravascular volume, and hopefully you can keep it there. Some people like to give 5 to 7 milliliters per kilogram prior to doing an induction to kind of ward off that hypotensive effect of your anesthetic inductions. Some practitioners give half the calculated fluid deficit before you do your induction. If you go slowly, you take your time, and you don't make big moves and stuff, hemodynamics can stay fairly stable. But the trend you're going to see when you look at, because we have monitors that display everything from your heart rate to your blood pressure to your A-line pressures to your CBPs, all that stuff is displayed graphically on a chart for you. So the general trend that you start to see is, I bring my patient in the room, they're a little bit comfortable because maybe I give them some Versed outside and grapple. I get in the room, their blood pressure is a little bit lower than it was out there. They're a little bit more comfortable than they were out there. So your blood pressure tries to stand a little bit lower, and then you tell them you're going to get them off to sleep. You start giving induction drugs, and the blood pressure gets a little bit lower, so you're starting to see this little dip. Then what do? the most stimulating thing you can do to a person. You stick this hard, cold piece of metal in their molecular space, and they go, ah! So you lift, and you put the tube in, and now your trend, blood pressure goes up, heart rate goes up. Now you get them intubated, you put them on the ventilator, you put on some volatile anesthetic agent, they slowly start to settle in, so from here, now they kind of start to go back down again, and then hopefully, if you've done everything okay, then they just start to level off. And your goal, all of our goals, is to have your patient just in this nice, what we call railroad tracks, where their blood pressure stays like this, and their heart rate stays like this. That's ideal, but that's what you're trying to do. And all the time, they want to do something different. So you have to do something different to keep them there. People are dynamic. They're not static. So you do things to them, the surgeon makes a decision, and their blood pressure goes up and down. So being a little bit ahead of the game, giving some extra fluid maybe up front, maybe not cranking your volatile agent on quite so high initially, and then forgetting about it. So now their end-tidal concentration's climbing, and their blood pressure's doing this. So all those things to keep in mind. That's your brain. In neurosurgeries and in CHF and in some thoracic surgeries, you may want to give less fluid. What's another good thing to keep low when you're talking about their brain? So you want to keep their ICP low. What causes your brain to swell? High levels of what? What?
Hypotonic.
Yeah? What about gases? You want to keep their CO2 lower. So in my cases, when I have somebody on the ventilator, I'm looking for an end-tidal CO2 of somewhere around 31, 32 for me. But in cases like this, you may want to hyperventilate your patient to keep their ICP lower, to keep their CO2 low. Because high levels of CO2 causes brain swelling. You want to give more fluid when you're doing a case that's like an open belly case, a large abdominal surgery, or somebody who's already hypovolemic. So maintenance fluids are continuously given. Different types of fluids that you give. You're trying to make up for their NPO status. You're trying to make up for their insensible losses. You're trying to make up for blood losses. Usually we replace all that stuff with Hypotonic Solutions. So in the operating room, most people get LR. Sometimes we give them monosaline. Renal patients need more or less fluid? Less. Okay. What do they normally give renal patients? Type of fluid? Normal. So here's my philosophy. If my patient's dry, they get in dialysis, they go to dialysis 3 days a week, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And they're dry. Let's say they've just come from hemodialysis, because that happens too. They go to dialysis and they bring them right to the OR after. They're going to be dry, right? If they're so dry that hemodynamically they're in trouble because they took up too much fluid, what do you want to do as far as their fluid? What would you do?
Use colloid? Because you can give less volume?
I would never want to expose anybody to colloid unless I had to. If I have to, I have to. But I try to avoid giving blood if I don't have to. Because people get exposed to all kinds of things when you give them blood. Much less likely that they're exposed to stuff now than before 1985 or ish, something like that. So here's my rule. If somebody needs fluid, give them fluid. Don't withhold fluid because they're a renal patient. Don't withhold fluid because they're a CHFer. I mean, do it in moderation, but if they need volume and they're telling you they need volume, give it to them. I want their urine output to be good. I don't want them to look like they're so concentrated that their kidneys are going to have a problem. So if they need fluid, give them fluid. And then what? Can you dialyze them after surgery? Now that the anesthetic agent's off, and now that they're more hemodynamically stable, send them back to dialysis just to take off fluid. You can always do that. But treat the patient. Don't just treat their disease. Treat what the patient needs for the short period of time that you're trying to save their life in the operating room. So do what you have to do. We know fluid moves back and forth between the interstitial space, the intracellular space, intravascular space, and it depends on the degree of surgical trauma. So we kind of already went over how we look at like an open wound and figure how much we want to replace insensible loss with. Post-op, within the next like 1 to 3 days, everything kind of tends to shift back to where it started. But during a trauma, during anesthesia, during a surgery, things tend to shift a lot more rapidly. So you keep them stable, you keep them hemodynamically stable, you send them back to the floor, you send them home. Normal healthy patients may go home a little bit intravascularly loaded. So what happens over time? Things start to shift out, they pee at home, and everything kind of goes back to home. Eating is a big thing that helps also. So here's going to be an example of an 80 kilogram guy who's been NPO for 10 hours. So initially, he's 80 kilograms. What's his maintenance rate going to be? 120, very good. He's been NPO for 10 hours. So what is his starting deficit? Talk me through the math. We want to hear you talking stuff through. So he's 80 kilograms. Your average maintenance is what? How'd you get that? 80 plus 40. So now you take that number, and he's been NPO for 10 hours. So you multiply what by what to get what?
120 times 10.
120 times 10. So his deficit for this 10 hours is how much? 1,200. So in the first hour, you replace how much of that? Half of it. So how much is that?
600.
600. So now you know in the first hour they're going to get 600, and in the next hour they're going to get how much is that remaining? A quarter.
1 quarter.
A quarter. So you start with 1,200. You went to 600 for half. What's half of 600?
300.
300. And then for the next hour, how much? There's your maintenance. There's your deficit, just like you guys know. So now you're dealing with third space loss. Is there any third space loss in the first hour?
No.
No. That gets calculated for the next hour. So what I'm saying, and I didn't write it down, so I'm going to explain it to you if you want to write it down. So I said for the first hour, they make a smaller-ish incision. So their estimated insensible loss was 4 per. Okay? I should revamp my slide and put that in there. But 4 for an insensible loss times how many kilograms was the guy? 80 is what? 320. The next hour, they didn't have enough access. So they made the incision a little bit bigger. So now, instead of being smaller-ish, it's kind of moderate. So I said, now the insensible loss went to 6. So I took 6 times 80, and I got 480. Now I hear, on the other side of the grade, you know, we need to open the guy. There's adhesions, there's fat,
This is real life.
all this stuff. So you have to be dynamic. You have to be able to go with the flow. And being dynamic and you being vigilant anesthetist, because you're the only thing that's keeping your patient from dying, because the surgeon's trying to kill him. So your job is to stay dynamic, assess your case constantly. And so now the incision was bigger, and I called it an 8. So 8 times 80, I got 640. Now we're going to go to your estimated blood loss. So for crystalloid, you replace blood in a ratio of what? 3 to 1. So for every 1 cc of blood you think they lost, which nobody loses 1 cc of blood, you're going to say to the surgeon, what do you think about EBL? 10, 1, 3. I'm like, no. I say, no. I'm looking in your canister. Before you told me you were going to irrigate, there was 300
Something.
of blood loss in there. Because all you were sucking out was blood that I saw. Now, sometimes that won't be the case. Sometimes there's an abscess. Sometimes there's a fluid collection or something, and they suck that out. So that's why, again, it's your job to look and be mindful and look at what's going on. Is there blood on the floor? Yeah. Did they drop a couple lap sponges on the floor? Yeah. Are the guy's shoes covered in blood? Yeah. So it's not just what you see in the canister. This is real life. I mean, this is what you have to take into account. So there wasn't really much blood loss during the first hour, but during the second hour, what I noticed was 100. So now you got to replace that with crystalloid. How much? 100 EBL, so 300 fluid. So you add that in there. Then the next hour, there was 250. So that's in addition to. So now you got to replace that with 750 cc's of fluid. And then in the last hour, you got a little bit better, starting to close a little bit. It's not a resident. Now it's 150. So you're just keeping track of all the blood loss that you see hour to hour. Because you don't want to look at blood at the very end of the case and go, oh my God, there's a liter of blood loss. I should have given them like 3 liters of crystalloid over the course of the case. So you keep running totals. And we'll have you make these strokes out in the room. So for the first hour, you move across the totals. So 600 and 120 to 720. That's what you should have given during the first hour of surgery. Then the next hour, you have your maintenance, you're replacing a quarter of your deficit, and they have another 320 in insensible loss from the small incision, and your EVO is 100, so you replace with 300, and you get a total of 1040. And you go like that across the whole way. So then your cumulative totals, you could get your cumulative total here for the first hour. What's it going to be? 720. Because there's nothing else to add to it until you get to your next hour. So your first hour is 720. What's your cumulative total for the second hour? What's it? 1760. Because now you're adding this and this. Your total from this hour, in addition to what you've already given, so your cumulative total should be 1760. The next hour, you had 1630 replacement. That's the last hour you were given the replacement for your NPO status. You get 1630, add it to 1760, you get 3390. And over the fourth hour, same thing. 1210 plus 3390, you get 2660.
These are fluid plans you would include on your care plan. So now you have an idea of how to do it.
Does that make sense?
Yes.
Are you sure? Keep in mind, these are ballpark numbers, right? Nothing is within a range. So if I do my calculations and I come up with 4 liters of crystalloid, and maybe even in there I've given some blood, that's above and beyond the crystalloid, the fluid replacement. Then that's what I get. 4 liters. Maybe you got 3,800, maybe you got 4,300. It's all good. It's all good. As long as you're involved. And as long as your patients seem hemodynamically stable. That's the main thing. So this is like an age-old question. What do? Start off with crystalloid, usually, unless your patient's coming to you with a really bad hemoglobin. I've never seen anybody come to the OR with a hemoglobin of 4. Not that was measured. That doesn't mean, I can tell you stories. I've had patients come to the OR from a statin with a lacerated kidney hanging out. Hanging out, awake and talking to me. A kid, compensated, right? I don't know what his hemoglobin was. That's, in every trauma we get, one person's doing the airway, one person's usually charting, and somebody's throwing in an A-line. Is an A-line easy to throw into somebody? I say throw in. Is it easy to put into somebody who's hemodynamically in the toilet? So what do we have to do? You have to make sure you have good IV access. That may mean another person or the person who intubated finishes the DL, gets them on the ventilator, and then puts in the central line. So when I say being a little bit ahead of the game is important, really important, because guess what? It may be you. In a trauma, it's not going to be just you. But you're going to have patients that come in that you know are going to need an A-line. There's going to be patients that come in and need an A-line and a central line. There's going to be patients that come in that need an A-line, a central line, and another peripheral IV. So the peripheral IV is where I go for first, because if I get a large bore in there, at least I can be giving fluid and setting up for my central line. So there's a lot of cases where the farther you are ahead and get your routine down, it'll stay in a good stead because the surgeons are waiting and other people are waiting for you to, I want to stick in a second large bore IV in case you need to give blood. I want to put an A-line in because I know they've had some cardiac issues and hemodynamic issues, so I want an A-line. So staying ahead of the game is really important. Having your mind, this plan, and whatever you think you need in the room, have it in the room. Do I need a glide scope? Do I need some other airway device? Am I going to put an A-line in? So I'm going to call the tech or somebody and say, hey, would you mind having a pressure bag set up for me in the room? I want to put an A-line in. So it's ready to go. And when you start IVs, when you start A-lines, don't have your IV tubing up there on a pole. You start your IV here, and you're like, okay, I'm in. Can somebody hand me the badge form? If you need it, have it right there. So what I do is I set up my IV, and I drape the IV tubing over the arm, so when I get in, it's right there ready for me to go. If I'm having an A-line, I put the pressure tubing over my patient's arm, start the A-line, hook it up. You can always be out of position, so you don't always have to stay at the head. You may have to go around the bed to get to the person's other arm and just turn your monitor so you can still visually, every once in a while, look up and see what's going on. And if you have to make an adjustment, back off on my agent. Increase my respiratory rate. You can do it from right there, but still be working here. So let's always set yourself up for success. Don't set yourself up for failure. And you're new, and we get it. We get it. We've all been there. So it's going to be frightening. And sometimes we're going to sit there and we're going to go, okay, how long do you let the blood pressure go? Oh, my agent's still up. We back up the agent. Or how long do you want this patient to be tachycardic? In the 130s. They start off in the 80s. You want to let them stay 130? No, I need to treat that. So maybe give a little bit of esmolol just to break that initial stimulation from your DL. Giving 10 esmolol is a great trick. Not a trick, but it's a great thing to know because you can DL somebody and their heart rate goes, you're taking a long time, they're kind of in the airway, you're stimulating them, and their heart rate goes from 80 to 130. So finish your DL, ABCs, right? Still ABCs, airway, breathing, circulation, sometimes you modify a little bit.
Airway book chair.
So, I mean, but finish your DL, because that's your main airway. You want to be able to breathe for somebody. Secure your tube, get them on the ventilator, put a little bit of agent on board and go, you know what, yeah, I don't want to leave it like that for right now. So break your routine, go get 10 of esmolol, give it IV, chart it, and then as you're doing other stuff, like putting on a bear hug, or helping to reposition the patient, or whatever, the esmolol's going in, and then all of a sudden your heart rate goes back to 80. And you're like, okay, now my pressure's better. So having your mind a plan. When this happens, this is probably a couple of the things I can try, but your other job is also not just looking at something and treating it and waiting. There's certain things you can do in your bag of tricks that you may want to do now, and there's other things you may want to do instead of that, because maybe I know when surgery starts and my patient gets more stimulated, this drug may be better to give than that drug. So, like, here's another scenario. I don't want to open it. Oh, so the other scenario is, let's say you got a guy or a girl who's coming in for tib hip fractures, and they're either going to do RIF or they're going to put IM nails in. So what do? They set up, they put a tourniquet on somebody, and they start the case. Tourniquet gets inflated. You make a mark of that in your chart. You do not want tourniquets up, because after 2 hours, what? They should probably be thinking about maybe releasing it, either for 20 minutes or taking it off if they're close to the end of the case. So tourniquets up, time's ticking on. After about the first hour, 2 hours, what do you see? Their heart rate starts going up. Their blood pressure starts going up. So your initial response is, maybe let me give a little bit of fentanyl. And it works. But then as time goes on, now my fentanyl's not working. So what do you decide to do? My heart rate's up, my blood pressure's up. Let me give you something kind of short acting. So I choose Esmolol. Pure beta 1, right? Lasts about how long? How long does Esmolol last? You know? Look that up. It's short acting. So your Esmolol works to get your heart rate down for a little bit. Your blood pressure comes down a little bit, maybe, because 10 milligrams isn't going to do a whole lot for your blood pressure. And then time's still going on, your tourniquet's still up. Now your heart rate is in the 120s, and your blood pressure is really high. So you have a couple choices to make. There are a few choices to make. I'll give you two. One is, I'm going to give labetalol, alpha and beta, lasts longer. Or you kind of think in the back of your head, maybe they're getting done soon, so I'm going to just ride it out. Or can I do something else that may be a better choice, that you can get off quickly if you need to, if the pressure starts dropping. So your tourniquet's up, it's 2 hours, your blood pressure and your heart rate are high. What do you want to do? So these are like the scenarios to think about. So I can tell you from experience, because I've made this mistake, I chose to give labetalol, not thinking. Because you have to be mindful about what's going on in the case, right? So lower leg, what's on the leg?
Tourniquet.
A tourniquet. So I chose to give 10 of labetalol. And maybe 20 seconds after I did this, I hear, tourniquet down. And I was like, forgot about the tourniquet. So what's been causing all these hemodynamic changes? That tourniquet. So you have to be mindful of what's going on in the case. You can't just forget about stuff. It's not like, yeah, if something gets out of whack, I'm just going to call somebody and they're going to tell me what to do. You're going to have to know what to do. So I heard tourniquet down. Now my blood pressure was kind of where I wanted it. Now the tourniquet and all that deep nociceptive stimulation is gone. Where'd my blood pressure go? In the toilet. So now what am I doing? I'm pushing phenylephrine, I'm pushing ephedrine, I'm backing off on my agent. Okay, so that's, what would be the better choice? What?
Situational awareness.
Situational awareness is always a better choice. What would be a better choice in that situation?
Esmolol or Pro.
Esmolol is not going to work.
No.
Propofol. Yeah.
I'm probably going to wait it out for a little bit, and because I'm thinking they've got to be letting. I'm looking at what they're doing. I'm looking over the drape, going, they've got to get this. Hey, we need to get the tourniquet down as quickly as possible, and it looks like they're about to. I'd probably wait it out. It's really hard because every second counts in your anesthesia world, and you're thinking, but you don't want to have happen I've done it too.
We all learn, you guys are gonna make mistakes, and you're gonna go, oh, God, I didn't do them.
Because labetalol is going to last a long time. So if you give that and then they drop the tourniquet, not only is it going to drop precipitously because of the tourniquet drop and all the fluids going back to the lower body, but then now it's also going to chemically do it because of what you did. So that's why you're going to have to chemically bring it back up.
So here's another choice that I figured out the hard way. What's something I can give this patient that I can get on quickly, that I can get their blood pressure down, and when I hear that the tourniquet's coming down, I can get rid of quickly. Yes. So out of all these choices, that's the choice. So what happens is I see my blood pressure going up. I keep coming up on my agent, and I keep watching. I keep coming up on my agent. And eventually, I find a place where their blood pressure is acceptable. 150? 120? Can you do anything about their heart rate? Can you do something about their heart rate briefly? Yeah, you can give Esmolol, but it's short acting. So now you're going to give your patient's heart rate doing this, right? Is that good for people? No. So what I choose to do is I camp on. The heart rate is what it is. Nothing I can do about it. As long as my pressure is stable, I'm good, because they're perfusing okay. Sometimes when people's heart rate gets super high, what happens to their blood pressure? It drops, right? So as long as I have pressure, which is ultimately more important, yes, there's more cardiac workload. Yes, there's more cardiac demand. Are you able to oxygenate them? Yeah. Turn up their oxygen if you have to. But as long as they're hemodynamically stable, crank up your agent, keep going up with your agent, vasodilate them out. There's really not an endpoint to how much agent you can give somebody. As long as their pressure is stable, so they got too much pressure because of the tourniquet pain, you're okay. Then when the tourniquet comes down, back off on your agent. Way back, way back. And their pressure, the agent will come off, and their pressure will stabilize. That's the better choice. So in all scenarios, you're gonna be confronted with a situation where maybe I can do 5 different things to get the desired effect. What's the best one of those 5 things I can do? That's your job. Your job is keeping your patient safe and stable.
You have a question?
So why wouldn't we? So you're saying this is pain induced, right?
The elevated heart rate and blood pressure from
So
the
why
tourniquet.
wouldn't we treat the pain? Like why wouldn't we give them fentanyl?
Okay.
You will give them some fentanyl.
You will.
But do you want them to breathe when they wake up?
Good question. It's a great question.
Just
Why don't you treat them with
think
fentanyl?
that thought.
True.
Because, again, you have to think about the situation. Because eventually the case is going to end. And eventually the tourniquet's going to come off. So what's a huge response to opioid for people? Respiratory depression. So you keep giving people fentanyl. You keep giving people fentanyl. You keep giving people fentanyl. And then the tourniquet comes down. And then the causative agent is gone. You back off on your agent. They're starting to wake up. Do they want to breathe? No.
They're too comfortable to breathe.
So then what do you do?
How much time is there between when you take off the tourniquet and you wake your patient up?
I can't answer that. I don't have a good answer. There's no standard. Some people take the tourniquet down because they want to see blood flow. What if they're doing like an anastomosis of an artery or something, and they want to make sure they have good blood flow? So they take the tourniquet down, and they get good blood flow, but then they put the tourniquet back up again because they want to include the blood flow to do the anastomosis properly. So it depends. It depends on the case. Sometimes surgeons will keep the tourniquet up until they're closed, and then they let the tourniquet down. Other times, they'll still have an incision, but they'll take the tourniquet down because they want to make sure the lower extremity, the foot, is perfusing with Doppler. So the incision is still open, but they want to make sure they don't have to go back in and something's wrong with the graft they put in or the anastomosis and undo it and redo it. So I can't answer the question. It's a valid question, but there's no pat answer because different surgeons do things different ways. And depending on the case, they may have to do it different ways. whether leaving it up till the very end and dressings are going on, or leave it up till the end and make sure that there's no bleeding, and then close, and then put the dressings on.
So the issue is you don't really know when the case is going to end.
Well, you will learn
You have an
that.
idea.
You will learn that depending on the surgeon and the case and all those kinds of things. In time, you will learn that. But you will not know that initially. And you don't want to over-narcotize someone that you know you're going to be waking up in the next 20 minutes.
Then you have to do Narcan.
Especially when you know
If
it's,
you're in Narcan,
when it's tourniquet pain.
yeah,
And if you give Narcan, then you've taken away all that good pain management you've done throughout the case.
have you guys ever given Narcan? Have you given all of it, or some of it?
Small dose.
Some of it.
So Narcan, the concentration in the vial is what?
Point
How much is in the
four.
vial?
Is it 4.4?
0.4.
Yeah.
So what we like to do is we'll take that 0.4 in 1 cc and distribute it into 10 cc's total volume. So now what's your concentration? It's not 0.4 per cc, it's 0.04. 0.04. So now you can safely maybe give 2 cc's and give them 0.08. See what it does. Because if you completely reverse somebody's narcotic, what's going to happen? They are going to be unglued. I mean, their heart rate's going to be up, their blood pressure's going to be sky high, they're going to be screaming in pain. And once you give it, can you give more opioid? You gotta wait. You can't. It's not going to work for you. So you don't want to burn a bridge. And that gets back to your question about giving opioid. You never want to burn a bridge, okay? So you're in PACU. What would be the harm in giving somebody 0.5 of Versed or 1 milligram of Versed? Does everybody have to get 2 in pre-op before you go back? So the rule is you can always give more drug. You can't take more. Basic rule in nursing. You can always give more. So with narcotics, would it hurt to get somebody back to breathing from being on a ventilator, get them back to breathing while still asleep, assess their respiratory status? Are they breathing 20 times a minute or 30 times a minute on their own? Or are they breathing 8? Now's your golden opportunity, if you start early, where your agent's a little bit lower, patient's breathing on their own while they're sleeping, and now you can start to work in narcotic. And then you titrate in narcotic based on the respiratory rate. So you know, before you pull that tube and emerge that patient, they're going to be comfortable. Somebody who's breathing 20 times a minute, probably not so comfortable. Someone who's breathing 8, 10, 12 times a minute, probably comfy. When people are uncomfortable, they breathe fast and slow. You don't want your person breathing fast and slow and hyperventilating themselves. You want them breathing like this. 500 cc ton of volumes. That's a comfortable person.
Really quick question. I'm kind of stuck on the ADL. So I'm sure it's because there's not much of a big difference, but you had 4x4s equal in soaked is 10 mLs. 4x8s is what I'm typically used to in the OR as a circulator. So is it only like 15 soaked, or how much are 4x8 Raytex? Probably
Raytex,
doesn't matter because they don't soak them a lot.
yeah, I mean, and again, you have to use your best judgment. Is this thing dripping, soaking wet, and it's just fake?
And it's an estimate.
Or
And it's not
is
really
it
that accurate.
or is it like a big lab?
Right.
Or is it right?
And it's the best you can do.
Yeah, and what they do is they take their sponges and they put them in, there's like a sheet with pockets in it. So you put them in the pockets and you kind of look at the whole thing and you go,
It's your
you
best
don't have
guess.
to count each individual one. They have them individually in the pockets, right? So you just look at all of them and you go, yeah, that one's soaked, that one's kind of dry, that one's, so the whole thing looks like maybe 100.
And as far as your replacement, it's based on their hemodynamics, more than a number that you're trying to estimate at how much did they lose. I think Dr. Shores is ready to start his class, and I know you guys have an exam. Thank you
Lord.
so much for being here.